Story 3. The Patient Who Kept Coming Back. My name is Dr. Sarah Kim. I'm 36 years old, and I drive a white 2022 Tesla Model 3 that I park in the physician-reserved section of the St. Vincent Medical Center parking garage, usually in spot P8. I'm 5 feet 7, weigh about 145 pounds, and I've been working as an emergency room physician here in Austin, Texas for 11 years. I specialize in emergency medicine, which means I see everything from heart attacks and car accidents to drug overdoses and domestic violence cases. But the case that still keeps me awake at night involved a patient whose condition seemed to deteriorate every time she left our care. The emergency department at St. Vincent's sees about 200 patients per day, and we have strict protocols for follow-up care. When we discharge a patient, we provide detailed instructions for recovery, prescription medications if needed, and clear guidelines about when to return for emergency care versus when to see their primary care physician. Most patients follow these instructions and recover without complications. But sometimes, you get a patient who becomes what we call a frequent flyer, someone who returns to the ER repeatedly, often with vague or escalating complaints that don't quite add up medically. On Thursday, September 14th, I first met Patricia Williams, a 44-year-old woman who worked as a receptionist at a dental office in North Austin. Patricia was brought in by ambulance after collapsing at work with what she described as severe abdominal pain, nausea, and dizziness. She was conscious and alert, about 5 feet 4 and maybe 160 pounds, with shoulder-length brown hair and the kind of tired eyes you see in people who work long hours for not enough money. "Doctor, the pain is right here," Patricia said, pressing her hand to her lower right abdomen. "It started this morning, but it's getting worse. I can barely stand up." I performed a thorough examination, ordered blood work, a urinalysis, and a CT scan of her abdomen and pelvis. Everything came back normal. Her white blood cell count was fine, ruling out appendicitis or infection. Her organs looked healthy on the CT scan. Even her urine test was completely clean. "Ms. Williams," I explained after reviewing all the results, "I can't find any medical cause for your symptoms. Your tests are all normal, and your pain seems to have improved since you arrived. It's possible you had a stomach bug, or maybe pulled a muscle. I'm going to discharge you with instructions to follow up with your primary care doctor if the symptoms continue." Patricia's expression immediately changed. "But doctor, you don't understand. The pain is still there. It's not better. I'm just trying to be brave about it. What if it's something serious that your tests missed?" "Ms. Williams, CT scans are very accurate. If there was something serious happening in your abdomen, we would have seen it. Sometimes these episodes resolve on their own." I discharged Patricia with instructions to rest, stay hydrated, and return to the ER only if she developed fever, vomiting, or if the pain became unbearable. She seemed reluctant to leave, but her boyfriend Anthony picked her up around 11 p.m., and I thought that was the end of it. 2 days later, on Saturday morning, Patricia was back. This time, she arrived by private car, brought in by the same boyfriend. "Dr. Kim, thank God you're here," Patricia said as soon as she saw me. "The pain never went away, and now it's spread to my back. I think something is seriously wrong." I examined Patricia again, noting that she looked more distressed than during her first visit. Her vital signs were stable, but she was clearly uncomfortable. I ordered another round of tests, including more detailed blood work and a different type of imaging. Again, everything came back normal. "Ms. Williams, I'm not seeing any changes from your last visit. Your blood work is perfect. Your scans are clean. Have you been following the discharge instructions? Are you taking any new medications or supplements?" "I've been doing exactly what you told me," Patricia said, and I could hear frustration creeping into her voice. "But the pain is getting worse, not better. You have to help me." This time, I spent more time talking with Patricia about her symptoms, trying to understand if there might be a psychological component to her condition. Stress, anxiety, and depression can all manifest as physical pain, especially abdominal discomfort. "Patricia, have you been under any unusual stress lately? Problems at work, relationship issues, financial concerns?" "Well," Patricia hesitated, "Anthony and I have been having some problems. and my boss has been threatening to cut my hours because the dental practice isn't doing well. But this isn't stress, doctor. This is real pain. I prescribed a mild anti-anxiety medication and referred her to her primary care physician for follow-up. Patricia left reluctantly, but she did leave. 4 days later, she was back again. This time, Patricia's symptoms had escalated dramatically. She was writhing on the gurney, claiming the pain was a 10 out of 10, and insisting that she was having some kind of internal bleeding. "Dr. Kim, I think I'm dying," Patricia gasped between what appeared to be waves of pain. "The pain is everywhere now. My stomach, my back, my chest, and I've been throwing up blood. You've been vomiting blood." This was a new symptom that could indicate a serious problem. When did this start? "This morning it was dark, red, almost black. I think something is rupturing inside me." I immediately ordered stat lab work, including tests for internal bleeding, and had Patricia connected to 4 fluids and pain medication. But when the results came back, there was no evidence of blood loss. Her hemoglobin and hematocrit levels were exactly the same as they'd been during her previous visits. "Ms. Williams, your blood work doesn't show any signs of internal bleeding. Are you sure you were vomiting blood? Or could it have been something else you ate or drank?" Patricia's demeanor shifted slightly. "I know what blood looks like, doctor. I'm not making this up." That's when I decided to dig deeper into Patricia's medical history. What I found was concerning. In the past year, Patricia had been to 3 different emergency rooms in the Austin area, a total of 23 times. Her complaints were always different: chest pain, severe headaches, difficulty breathing, joint pain, skin rashes, but the pattern was always the same. Extensive testing would reveal nothing wrong. She'd be discharged. And then she'd return a few days later with new or escalated symptoms. "Patricia," I said carefully, "I've been reviewing your medical history, and I notice you've been to several emergency rooms quite frequently. Can you help me understand what's been going on?" For the first time, Patricia looked genuinely uncomfortable. "I've been having a lot of health problems lately. Different doctors keep telling me nothing's wrong, but I know my body. I know when something isn't right. I understand that. But sometimes, when we're under stress or dealing with anxiety, our bodies can create very real physical symptoms. Have you considered talking to a counselor or therapist about, I'm not crazy?" Patricia's voice rose sharply. "I'm not making this up for attention. There is something wrong with me, and you doctors are too lazy or too stupid to find it." That outburst told me everything I needed to know. Patricia wasn't faking her symptoms. She genuinely believed she was sick. But after multiple normal test results and consultations with specialists, it was clear that her problems were psychological rather than physical. "Ms. Williams, I don't think you're crazy, and I don't think you're making anything up. But I do think you might benefit from talking to someone about the stress you're experiencing. Mental health issues can cause very real physical symptoms." Patricia stared at me for a long moment, and I could see something calculating in her expression. "So you're refusing to treat me? You're just going to send me home to die?" "I'm not refusing to treat you. I'm suggesting that we explore other causes for your symptoms, including psychological factors." "I want a second opinion," Patricia announced. "I want to see another doctor. I want more tests. If something happens to me because you missed something, I'm going to sue this hospital for everything it's worth." That's when Patricia's behavior became truly concerning. She started demanding to see the hospital administrator, threatening to call the medical board to file complaints against me, and insisting that she was going to contact the local news about how St. Vincent's was refusing to treat sick patients. "Ms. Williams, you're welcome to seek care elsewhere, but making threats against medical staff is not appropriate. If you continue this behavior, I'll have no choice but to call security." "Go ahead," Patricia shouted. "Call security. Throw a sick woman out of the hospital. See how that looks in the newspapers." Over the next 2 hours, Patricia became increasingly agitated and disruptive. She was yelling at nurses, accusing the lab technicians of tampering with her blood samples, and claiming that I was part of some kind of conspiracy to deny her medical care. Finally, I made the decision to have Patricia evaluated by our psychiatric team. Her behavior suggested she might be experiencing some kind of mental health crisis, possibly related to anxiety, depression, or even a condition called Munchausen syndrome, where patients fake or induce symptoms to get medical attention. When the psychiatric team arrived, Patricia's entire demeanor changed again. She became calm, cooperative, and reasonable, explaining that she was just worried about her health and frustrated that no one could find the cause of her pain. "Doctor," she said to the psychiatrist, "I'm not crazy, I'm just scared." "Wouldn't you be scared if you were in pain and no one could tell you why?" The psychiatric evaluation concluded that Patricia was not an immediate danger to herself or others, but recommended outpatient mental health services and suggested that she might be suffering from somatic symptom disorder, a condition where psychological distress manifests as physical symptoms. Patricia was discharged with a referral to a mental health clinic and instructions not to return to the emergency department unless she was experiencing a genuine medical emergency. But she was back 6 days later, this time claiming she was having a heart attack. This pattern continued for 2 months. Patricia would return every few days with new symptoms, stroke-like symptoms, severe allergic reactions, kidney stones, appendicitis. Each time, extensive testing would reveal nothing wrong. Each time, she would become increasingly hostile and demanding when told her tests were normal. Finally, after her 8th visit in 10 weeks, the hospital administration made the difficult decision to ban Patricia from seeking non-emergency care at St. Vincent's. She could still come to the ER if she was brought by ambulance with life-threatening symptoms, but she could not walk in for routine complaints. The last time I saw Patricia was 3 months later. She was brought in by ambulance after a serious car accident. She'd been rear-ended while stopped at a traffic light. She had genuine injuries this time: a concussion, 2 broken ribs, and a fractured wrist. As I treated her real injuries, Patricia looked at me with something between gratitude and sadness. "Dr. Kim," she said quietly, "I know you think I'm crazy, but I really was in pain all those times. Maybe not the kind of pain you can see on a CT scan, but it was real to me." I realized then that Patricia's frequent visits weren't about attention-seeking or trying to game the system. She was genuinely suffering, just not from the physical ailments she described. Her pain was emotional, psychological, and very real. But instead of addressing those underlying issues, she'd gotten trapped in a cycle of seeking medical solutions to non-medical problems. Patricia recovered from her car accident injuries and was discharged with appropriate follow-up care. I never saw her in our emergency department again, and I hope that means she finally got the mental health support she needed. But her case taught me something important about the intersection of physical and mental health. Sometimes the most challenging patients aren't the ones with complex medical conditions, they're the ones whose real illness can't be diagnosed with blood tests or imaging studies. Have you ever dealt with someone who seemed to be seeking medical attention for non-medical reasons? Do you think emergency departments are equipped to handle patients with primarily psychological needs? Or should we be doing more to connect these patients with mental health resources before they reach crisis levels? I'd love to hear from other healthcare workers about how you balance compassion with practical limitations when treating frequent flyers like Patricia. My name is Marcus Johnson. I'm 33 years old, and I drive a blue 2019 Honda Civic that I park in Section A of the employee parking garage, always trying to get spot A15 because it's closest to the employee entrance. I'm 6'0", weigh about 180 pounds, and I've been working as a security supervisor at St. Vincent Medical Center for 9 years. In that time, I've dealt with everything from drunk drivers brought in by ambulance to gang members trying to finish fights that started on the street. But the most unsettling situation I've ever handled involved a patient who simply refused to believe his treatment was over. St. Vincent's discharge policy is straightforward. Once a doctor clears you for release, you have 2 hours to arrange transportation and leave the premises. We're not a hotel, and we need the beds for incoming patients. Most people understand this. They're usually eager to get home after days or weeks of hospital food and uncomfortable beds. But every once in a while, you get someone who sees the hospital as a safe haven from whatever problems are waiting for them in the real world. On Wednesday morning, October 25th, at exactly 8:47 a.m., I got a call from discharge planning about a problem patient in room 218. Gerald Hoffman, a 58-year-old homeless man, had been treated for pneumonia for 6 days and was medically cleared for discharge. His insurance through the state would cover a taxi ride to the downtown Austin shelter, but Gerald was refusing to leave. He says he's still sick, explained Janet Morrison, the discharge coordinator. Dr. Peterson examined him this morning and found nothing wrong, but Gerald insists he's having chest pains and difficulty breathing. We think he's faking symptoms to extend his stay. Gerald Hoffman was about 5 feet 8, maybe 140 pounds, soaking wet, with long gray hair and a beard that looked like it hadn't been trimmed in months. His clothes, which we'd washed and returned to him, were threadbare and patched in multiple places. He'd been living on the streets for approximately 3 years, according to his intake paperwork, and this was his 4th admission to St. Vincent's in the past year. When I arrived at room 218, Gerald was sitting on the edge of his bed, fully dressed but making no move to pack his few belongings. "Mr. Hoffman," I said as professionally as possible, "I understand you're concerned about your health, but Dr. Peterson has cleared you for discharge. We need this room for incoming patients." Gerald looked up at me with watery blue eyes that held more intelligence than I had expected. "You don't understand, Officer Johnson. I can feel it in my chest. There's still something wrong. If I leave now, and something happens to me, it'll be on your conscience. Sir, if you're experiencing new symptoms, the nurses can have Dr. Peterson re-examine you. But if he clears you again, you'll need to leave the hospital." "I've already been examined 3 times this morning," Gerald said with a slight smile. "Each time, I tell them about the chest pains, and each time they say I'm fine. But I know my body, and I know I'm not ready to go back out there." That's when I realized what was really happening. Gerald wasn't worried about his health. He was terrified of returning to the streets. The hospital represented safety, warmth, regular meals, and people who were required to treat him with basic human dignity. Outside these walls, he was just another homeless man that most people crossed the street to avoid. "Mr. Hoffman," I said, sitting down in the visitor's chair, "I understand this is difficult, but we have social workers who can help you find housing assistance, job training programs." "You don't understand anything," Gerald interrupted, and for the first time, there was an edge to his voice. "I've been through those programs. I've filled out those forms. I've sat in those waiting rooms for hours just to be told there's no space, no funding, no help available. This hospital is the only place in this entire city that has to take care of me. And now you want to throw me back out on the street to die." I tried a different approach. "Sir, there's a shelter downtown that has space available. The taxi is already arranged." "The shelter?" Gerald laughed, but there was no humor in it. "You mean the place where they steal your shoes while you sleep? Where you have to fight for a spot on the floor? Where they kick you out at 6 a.m., regardless of the weather?" "No thank you, Officer Johnson. I'll take my chances here." Over the next hour, I watched Gerald transform from a compliant patient into something much more concerning. Every time a nurse entered the room, he would suddenly double over in apparent pain, clutching his chest and gasping for breath. The performances were increasingly dramatic, and when the medical staff would examine him, he'd become belligerent if they suggested he was faking. "You people took an oath," he shouted at Dr. Peterson during the 4th examination. "You swore to do no harm, and you're trying to send a sick man out to die in the cold." "Mr. Hoffman," Dr. Peterson said patiently, "your vital signs are normal, your blood work is clear, and your chest x-ray shows no signs of infection. You are medically stable for discharge." "Then you're incompetent," Gerald snapped. "I want a second opinion. I want to see a specialist. I want more tests." That's when Gerald's strategy became clear to me. He was going to demand test after test, second opinion after second opinion, anything to extend his stay. And if we refused, he'd become increasingly disruptive until we had no choice but to keep him for psychiatric evaluation. Around 2 p.m., Gerald escalated his tactics. When the discharge nurse came to escort him out, he collapsed on the floor, claiming he was having a heart attack. "Call 911. He wheezed dramatically. "I'm having chest pains." "This is exactly what I was trying to tell you." Dr. Peterson ordered an EKG, which came back completely normal. Gerald then claimed the machine was broken. When they brought in a second EKG machine, Gerald said the technician didn't know how to use it properly. "I'm not leaving this hospital until someone takes my symptoms seriously," Gerald announced to everyone in the room. "And if you try to force me out, I'll collapse on the sidewalk right in front of the main entrance, where everyone can see how St. Vincent Medical Center treats its patients." That's when I realized Gerald wasn't just trying to extend his stay. He was threatening the hospital's reputation. A homeless man collapsing in front of our main entrance, claiming we'd refused him medical care, would be a public relations nightmare. Mr. Hoffman, I said carefully, if you're truly experiencing medical symptoms, we want to help you. But if you're making false claims about chest pains and heart problems, that's considered fraud. Gerald's expression hardened. Are you calling me a liar, Officer Johnson? Are you saying I don't know when I'm in pain? I'm saying that if Dr. Peterson clears you for discharge and you continue to claim medical emergencies, we'll have no choice but to involve the Austin Police Department. Good, Gerald said with a cold smile. Call them. Let them arrest a sick man for the crime of being poor and homeless. See how that looks on the evening news. For the next 3 hours, Gerald turned room 218 into his personal fortress. He barricaded himself in the bathroom when discharge personnel tried to enter. He pulled the emergency call button repeatedly, claiming shortness of breath each time nurses responded. He even called 911 from the room phone, telling the dispatcher that St. Vincent Medical Center was trying to force a heart patient onto the streets. By 6 p.m., Gerald had been medically cleared for discharge 4 times by 3 different doctors. He'd had 2 EKGs, a chest x-ray, blood work, and a complete physical examination. Everything was normal, but he refused to leave. That's when Dr. Peterson made the decision that Gerald had been counting on. Mr. Johnson, Dr. Peterson said quietly, pulling me aside in the hallway, I'm ordering a psychiatric evaluation. If Mr. Hoffman is genuinely delusional about his medical condition, he may be a danger to himself. We'll need to hold him for 72-hour observation. Gerald had one. He'd successfully manipulated the system to get exactly what he wanted, an extended stay at the hospital. But his victory came with a cost that I don't think he'd considered. A 72-hour psychiatric hold meant Gerald would be transferred to the locked psychiatric ward. He wouldn't be in a regular room with cable TV and room service. He'd be in a sterile, monitored environment with patients who had serious mental health issues. He wouldn't be able to leave the ward, wouldn't have access to outside phone calls, and wouldn't be able to manipulate staff with fake medical emergencies. When the psychiatric team arrived to transfer Gerald, his whole demeanor changed. Wait, he said, as they approached his bed. I think I'm feeling better now. Maybe I was just tired. I'm ready to go to the shelter, but it was too late. Once Dr. Peterson had ordered the psychiatric evaluation, Gerald was committed to the 72-hour hold. As they wheeled him toward the psychiatric ward, Gerald looked at me with something between defeat and rage. You think you're so smart, don't you? He said quietly. But I'll be back. Maybe not next week, maybe not next month, but I'll be back. And next time, I'll be smarter about it. Gerald was released from the psychiatric ward after 72 hours. And true to his word, he was readmitted to St. Vincent's 2 months later with symptoms of food poisoning. Then again 6 weeks after that with a suspected broken rib. Each time, he tried new tactics to extend his stay, and each time, we eventually had to force him to leave. I still see Gerald around downtown Austin sometimes, usually near the bus station or outside the public library. He always nods at me like we're old friends who shared some kind of understanding. In a way, I guess we did. The thing that bothers me most about the Gerald Hoffman situation isn't that he tried to game the system, it's that the system forces people like him to become manipulative just to survive. How desperate do you have to be to fake a heart attack just to get a warm bed and 3 meals a day? Have you ever encountered someone who was so desperate for help that they resorted to deception or manipulation? Do you think hospitals have a responsibility to provide social services beyond medical care? Or should we focus strictly on treating illness and injury? I'd love to hear from other healthcare workers about how you balance compassion with policy. Because situations like Gerald's happen more often than most people realize.